All right, Charlie, welcome. I guess welcome back to sort of this Zoom call here that we're doing this on because we actually spoke yesterday for the Physio Network podcast, and we're doing a podcast now for Forward Physio. So, welcome to the show, and thanks very much for joining me again. Today, the topic is sciatica and all things related to its myths and its diagnoses and its treatments. But before we get into that, can you give everyone a little bit of an introduction into who you are, what you do, and sort of how you got interested in this topic of sciatica?
Yeah, so cheers, Noah. Yeah, I'm getting deja vu, I think, to be fair, mate, because yeah, we've never really spoke before, and then we've caught up yesterday, and we're catching up today, which is quite nice. And yeah, big fan of Physio Network, big fan of your podcast. It gets me through my long commutes to work, so it's a pleasure to be on here. So thank you very much.
Pleasure to have you.
For those who perhaps don't know of me, I'm a physio. I work as a first contact physiotherapist in the UK. I'm based in the southwest, so in a city called Bristol. The first contact role is, I think it's quite unique to the UK in fairness, in the sense that it's a role that works in primary care or general practice. It's a little bit more specialist, so it's more of an assessment. And essentially, we see people in that first port of call without any prior assessment from a doctor, a specialist physio, or anything like that. So it's having a good awareness of musculoskeletal pathology and how to manage it with advice and exercise, etc. But also, I guess, some of those weird and wonderfuls and like medical masqueraders, which I like to call. And that's really, I guess, quite a key interest of mine is sciatica, which we're going to talk about today, and then perhaps some of the more sinister, serious pathology, which I've sort of created my own course on and do a lot of sort of lecturing and bits and bobs for various sort of websites and platforms through that, really. So, yeah, thank you for having me on. And I mean, for sciatica, I don't really know what caught my interest in it, to be honest. There's a couple of heavy hitters out there that have done quite a lot on the topic as well. So Tom Jesson, who I know you're aware of, he's a physio that was in the UK and he's now based in Texas in the States. And I remember during COVID and stuff, reading a lot of his blogs and listening to some of his like podcasts and things. And I guess really it kind of snowballed from there.
Hmm. So Tom Justin being one of those big heavy hitters, who would another one be?
So Adam Dobson, who
Yeah.
is a friend of mine as well, sort of, he's based again in sort of the northeast of the UK. He's a spinal specialist that is again quite interested in sort of sciatica, lumbar radicular pain, which I know we're going to talk about in a bit more detail in a second. Yeah, I think, just sort of those two who I've had a fairly sort of loose communication with as well. It's been
Yeah.
quite nice, I guess, to like bounce ideas off of one another and sort of see some of the stuff that they've put out. And hopefully they think the same about me.
Well, I know you've created a lot of content out there already, like related to this, so I'm sure that they do. Um, when it comes to that course that you teach, is that just related to spinal pathologies, like red flags related to the spine, or just sort of any red flag that you may see in a physio setting?
Yeah, so I've delivered a 1 day sort of face-to-face course end of last year, and hopefully this year I've got some sort of online sort of Zoom webinars that are going to be run half day, full day, potentially some more face-to-face stuff as well, which would be pretty cool. And mainly spinal red flags. Yeah, you're right.
Hmm.
A little bit more so upper limb as well, though. So cranial nerve assessments, so sort of, vascular pathologies of the head and neck, vascular stuff of the lower limb, and some shoulder red flags as well. So it, I'd like to think it's fairly comprehensive.
Yeah,
I'm
sounds like
maybe
it.
not. I'm maybe not quite at the levels of some of the physios that have also got courses on that topic, but yeah, hopefully the feedback's been good, and yeah, long may it continue. Fingers crossed.
Yeah, and given the position that you're in, that unique position of, like seeing these people with more complex conditions and sort of needing to screen them, I'd imagine that you probably see red flags a little bit more than, the physio that just works in a private practice setting, who still definitely needs to be aware of all of these things, but probably doesn't have as much experience as you with that, right?
Yeah, I mean, I don't know if it's just I'm a bit of a magnet towards it, or perhaps maybe I'm a bit more thorough with my assessments. But yeah, I seem to pick up quite a lot. Like last year, for example, I had four confirmed cauda equinas in a year,
Whoa.
and you hear that there's that saying, isn't there, that you only see sort of one in your lifetime, but I don't think that's particularly true. I think. Uh, Certainly in the UK, I think it's harder and harder to see clinicians early doors and perhaps to see sort of, general practitioners or specialist physios. So more sinister pathology is walking around out there. And, you mentioned
Yeah.
private physios and stuff as well. But again, in the UK, probably they are seeing more face-to-face, like first contact appointments. So that's kind of like my USP for the course, really, is that I think irrespective of what setting you're in, you probably are seeing them in that first initial contact because they've either been waiting for months and months and months before they see somebody in secondary care, or they're seeing somebody privately because they can't see anybody on the National Health Service, or perhaps, yeah, they're coming to somebody like me who works in that role
Hmm.
fairly sort of exclusively.
Yeah. Yeah. I know in Canada, it's a little bit weird where it's often difficult to see a physician or your family doctor for a lot of people. There's millions of people in my province that don't have a family doctor. So that sometimes they are going to physio first, or sometimes it's a walk-in clinic. But those walk-in clinics, it could just be a little bit of a busy, rushed setting sometimes, and they don't
Okay.
always screen everything that they should. So I actually saw a cauda equina as well earlier this year, and I've sent a few people to the ER. So it's definitely still important to be aware of all
Mm.
those red flags, even if you think you're in a setting where you may not see much of it, like a sports medicine clinic, like myself. Um,
Yeah, absolutely.
yeah. So sciatica, it's one of those areas where there's so much misinformation and confusion about it. I think largely, as we discussed a little bit before we started recording, because of social media, everyone has the magic cure for it. Everybody sort of has, I guess, like a different diagnosis criteria or diagnostic criteria for it. So before we discuss diagnosis and treatment, I want to chat with you about what actually may be wrong with that term sciatica itself. So could you go into that for us?
Yeah, so I think it, I quite like the term still in terms of explaining that to patients because I think it's been around for, I think, hundreds and hundreds of years. I think, the first time it was sort of introduced was in the Greeks. The caveat to that, though, is it's inaccurate. So it's not really like nocibic. It doesn't really cause harm to the patient. They don't really worry a huge amount compared to something like shoulder impingement. But it's very rare for you to get an isolated sciatic nerve problem, so like a mononeuropathy. Um, I guess the only time would be, if you've been shot in the bum or stabbed in the bum or something is sort of growing in and around that deep gluteal space. So, perhaps a malignancy or something like that that could be
Mm,
compressing or irritating or cause trauma to that nerve. So I guess like the experts and the people that do a lot of research in this field. So one of them's Anina Schmid, and some of her colleagues released a paper in 2023, and it was kind of, I guess, a bit of an expert consensus, which essentially they sort of listed it under this umbrella term called spine-related leg pain, and in
mm,
that you've got lots of different sorts of like nomenclatures, terminologies for different causes of leg pain. So some of that's somatic referred, some of that's a painful radiculopathy, lumbosacral radicular pain. The list goes on, I guess. So it's a little bit more accurate anatomically. Um, and it's related to obviously the fact that it's associated with a spinal nerve root. So as it's
Hmm.
exiting through that foramen, as opposed to it being the sciatic nerve itself as it passes through that deep gluteal space.
Right. So if it's affecting a nerve root, and that's sort of what we think is causing the pain. A lot of the time when someone is having these sciatica symptoms, most of the time it's because of something like a disc herniation, right?
Yeah. So I think when you look
So,
at the when you look at some of the literature around it, it's 80-ish%, 8 out of 10 cases are normally from a disc herniation. And then the
right,
rest is you know, age-related changes, osteoarthritic changes to the spine, etc., etc., other pathologies and stuff that might cause it in that
right.
region.
So then if it's a spinal pathology like something like a disc herniation that's impacting that nerve root, that will then eventually sort of turn into the sciatic nerve. But that nerve root itself. It's not the sciatic nerve. So in essence, I guess that's sort of why it's better to call it like spine-related leg pain or a lumbar or lumbosacral, like radicular pain. So more so related to it's irritating the nerve, it's in the spine, but it may not just be the sciatic nerve itself. And before chatting with you, now that we speak about it, I think for a lot of people like that may make sense. But I know for myself, even with my explanations to patients, I was sort of saying like, oh yeah, like the sciatic nerve goes down your leg. And I was most of my explanations were sort of like more so revolving around using that sciatic nerve as the reason for why they're in pain, but that may not be so accurate.
Yeah, I think certainly that's the case. I think just in terms of like for ease and an explanation to patients, it's still maybe okay to use sciatica.
Hmm.
Um, to an extent, I think that would depend who you ask and how sort of fixated people are on different terminologies. But I will still be quite loose and say that I'm happy to call it sciatica. Just my explanation would be, as you said, around it being more to do with the spinal nerve roots as opposed to just this nerve on its own. And I guess the other key caveat is that you can have a mixed sort of leg pain presentation. So, certainly the nerve can be affected, the nerve root, but you've also got some of those somatic structures like the disc, the joint, the soft tissue, which can also be irritated,
Mm.
um, which is often why like the leg pain can be quite vague and I guess doesn't always conform to what we consider to be like neuropathic pain, if that makes sense.
Yeah, yeah. I guess another important distinction here is that a lot of the time when people think it is purely the sciatic nerve that's causing symptoms, they tend to zoom in on the butt, right? On that
Mm,
deep gluteal space. And then we were calling it something like piriformis syndrome, right? So
yeah.
how does piriformis syndrome happen? How common is that if it does happen, or is it just a complete myth?
That's a good question. I think again, it's perhaps a little bit outdated in terms of its terminology. Um, there's lots of research papers now which sort of, I guess, kind of discuss how instead we should be calling it deep gluteal space syndrome, because in that sort of like gluteal region around the buttock, there's lots of different structures there that could potentially be causing some form of irritation to that sciatic nerve. So not just the piriformis, you've got your deep internal rotators, deep external rotators, ligaments, etc. All of those types of structures that sit in that region. If you look at some of the literature, I can't pronounce their names, but there was some stuff done in like a GP setting, and they seem to think it could be as high as like 16% of
Hmm.
sciatic cases are instead to do with this sort of like piriformis deep gluteal syndrome. I wouldn't say sort of anecdotally in my experience that's the case though. I've never really come across any in my experience if
Hmm.
sort of isolated to that region. And the other key caveat is that people that have radicular leg pain probably one of the key areas that they also get discomfort in is their buttock.
Hmm.
And I don't really, I have access to imaging and stuff, and I wouldn't say I'm ever really MRIing pelvises and hips
Mm.
exclusively to look for that.
Right. Right. If How would a clinician or a patient with sciatica differentiate between if that pain was coming from their spine versus coming from that deep gluteal space in the bum?
Yeah, that's a good question. I don't think we can confidently
Mm,
say. I think yeah, I don't think we can with confidence isolate the two. Um, if you look at some of the tests and stuff, you've got, different types of stretches. So like a passive sort of piriformis stretch where you're sort of flexing, abducting, and then externally rotating the hip and the pelvis. Thought to maybe elicit symptoms, and then you've got some stuff where people can do, that or slightly different hip movements against contraction, but they're quite awkward tests and they're quite
mhm,
difficult to elicit. And I don't think, the likelihood of you getting a false positive where they say they're getting pain, but it could be due to something completely different. I wouldn't really hold my hat on anything specific. They do say with like piriformis, deep gluteal syndrome, sitting can be really provocative for it. But then that's also the case with like sciatica, usually.
yeah. Yeah.
Um, you might argue, flexion or movements of the spine, lumbar spine might elicit it a little bit more, but probably not.
Right. Yeah.
That's a good point. That's a good point. There might be someone out there that tells me, no, I'm wrong, but I wouldn't be able to put my hat on anything confidently and say, this is what you do versus this.
Right. I think another thing that will help people is just going back to the probabilities. The odds are is that most of the time it will be because of some sort of condition or pathology related to the spine. It's like this piriformis syndrome doesn't seem to be as common or as prevalent as we once thought, right?
Yeah, agreed. I
Yeah.
think for me, I would be always looking at ruling out the spine first, and then if somebody's got real like significant buttock pain, I'm probably thinking, is this more of an intra-articular hip problem before I'm thinking of like soft tissue, deep gluteal space stuff. So is it hip OA? Is it femoroacetabular impingement? Have they got a dysplasic hip? Those types of things.
Hmm. So speaking of sort of like ruling things out, differentiating between these different regions, how do you even diagnose sciatica in the first place? And I think this is so important because, again, as we said earlier, on social media, the misdiagnosis for sciatica seems so common. And not just that, but also in the clinic. There's so many people that have that I've worked with, and I've heard this story from many, many other clinicians, including yourself, where someone comes in and they say like, "Oh, I'm dealing with sciatica," and then you dig into it a little bit, and it doesn't seem like they have it at all, and it seems like something that's completely different. So there's a lot of things that can masquerade as it, right? So can we talk about how you diagnose sciatica and how we differentiate that between other common conditions that may masquerade as sciatica?
Sure. Yeah. So I think probably the key thing is that initially, not always, but maybe eight, nine times out of 10, your demographic is normally sort of like that more middle-age patient. So, maybe early to late 30s up to maybe sort of like early to late 50s, give or take. And as you said, that's because most of the time it's because of a disc herniation. Usually, that's when they're kind of like at their most prevalent, I guess, particularly like those more acute, subacute disc herniations that typically would cause some of those symptoms. If you then look at things and ways that you can discriminate it between perhaps other causes of leg pain, there's a really nice paper from 2018, so by Steins et al., that was again done in the UK, done in primary care, so sort of general practice, basically had a ton of people come in. So I think over 600 patients who sort of rocked up to general practice with back pain and leg pain. They had 7 clinicians and they assessed them using different sort of like clinical criteria and characteristics. Um, and they compared that to a reference standard. I'm not like super good at analyzing papers, but we'll go with it. Um, and they then sort of tried to they sort of gauge their confidence on how confident they were that it was sciatica versus not. And I think they had to have over 70 or 80% confidence in the diagnosis. And they basically
Mm.
came up with 5 clinical features. So that was leg pain that is worse than the back pain. Typically, leg pain that's below the knee is more common for something like radicular leg pain. Some form of subjective sensory change. So, tingling, pins and needles, dysesthesia, so, hot, cold water, ants crawling on them, tight, restrictive, all of those types of weird and wonderful sensations that we know can sort of be the source of nerve root pain. Um, they had to have some kind of physical finding, so some form of objective neurological deficit, so sensory disturbance compared to the other side, potentially some weakness or some form of like reflex change, and then a positive straight leg raise. So that's essentially reduced range of motion compared to the opposite side, and it brings on their painful symptoms, is kind of what they were looking at. And out of those 5 tests, it was scored out of 10. If you got 5 or more, so they were weighted slightly differently, but if you got 5 or more, the sort of probability that it seems to be sort of sciatica was over 80%.
Mm.
Um, that's a clinical tool though, so it's something that's just kind of, I guess, used to aid your suspicion. We don't really have any like robust like diagnostic criteria as such as of yet. But
Mm.
that's kind of the best that we've got at the minute.
A lot of those things there are subjective, right? So you make sure that you actually have to listen to your patient and listen to them describe the nature of their pain to look for that pain below the knee and that
Mm.
leg pain worse than their back pain. Um, and then something like a straight leg raise, as you mentioned, can help increase your suspicion, but it doesn't sound like there's any tests that we can do that with 100% confidence will give us a diagnosis of sciatica, right?
Yeah, I would agree. Yeah.
I think that's rarely the case. I think there's rarely an amazing objective test that can help rule something in. And I mean the only instances that I could think of are just, like maybe the ACL, there's some pretty good tests for that. Achilles ruptures, there's some decent tests. I think when we're mainly dealing with like these ligament ruptures where we're able to manipulate a very manipulable or a joint that's easy to manipulate. Other than that, when it comes to something like in the back or all these areas where we can't isolate certain things, I think it's really, really difficult to have an amazing objective test.
Yeah, I would agree 100%. And I think that's kind of the issue with a lot of stuff that you see on sort of socials and with certain clinicians is that they kind of go into it with like 100% confidence saying if it's this or this, then it's discogenic back pain or it's your facet joint or X, Y, and Z. And rarely is that the case.
Right. And I guess that's why we call most of this non-specific low back pain because it's not because and that like I know that's sort of unrelated to what we're talking about here, but most of the time, well, no, I shouldn't say most of the time, but a lot of clinicians think that non-specific low back pain means that there's nothing causing pain in the back, but it more so means that we can't reliably identify what that sort of source may be.
Yeah.
Um, Similar to how with sciatica, it's maybe sometimes difficult to differentiate what part of that nerve is irritated, but it does seem like most of the time it is related to something in the back. I think one of the trickiest things when it comes to the diagnosis of sciatica is differentiating it between somatic referred leg pain. Because sometimes people have back pain And because of just the weirdness of the nervous system and some funky things that go on with its sensitivity, sometimes when you have pain coming from one area, it could spread and radiate. And sometimes that back pain can sort of spread down to the leg. And I think a lot of the time that leads to this false diagnosis of sciatica. So how do you differentiate between that and a true sciatica?
Yeah, a really good question. I think there's a couple of key things that can help differentiate between the two. With somatic, it tends to be a little bit different in the sense that symptoms are more dull, achy, diffuse, as opposed to sciatica, radicular pain, which is more sharp, burning, lancinating discomfort. Somatic as well, routinely is above the knee, so it's more proximal in terms of its
Hmm.
pain locality. And it's usually on a sort of similar level in terms of intensity compared to the back pain in a lot of people. And then it's maybe less likely that you would see a positive neurodynamic test, but not always. When it comes to like radicular leg pain, you're looking for those neuropathic pain descriptors. As we said, it's below the knee. Some of the literature and some of the studies that have looked at that, they kind of hold their hat on sensory disturbances as well. So
Mm.
paresthesia, dysesthesia, those types of things, which we know will be coming from the nerve root or perhaps one of the peripheral nerves, is a lot more common with sort of like nerve pain. If you get really sort of geeky and clinical with it, again, sort of Anina Schmidt and some of her teams, and sort of like the neuropathic like pain sort of organization and stuff, they've basically suggested that you need those neuropathic pain descriptors. It then needs to be in sort of like a cutaneous dermatonal region. It then needs to be followed up with some form of objective physical test that's positive. So some
Mm.
sensory disturbance. And then you need to confirm that to a reference standard, so an MRI, for it to be definitive, like nerve pain. But I mean, the
Right.
chances of you doing that in clinic, especially sort of for a first initial assessment, is pretty rare. You know, you're not going to be sending people for imaging all of the time. It's not feasible. So I prefer just some of those key sort of easy tips that I mentioned at the start, rather than perhaps the more like academic
Yeah,
literature.
that makes sense. And we're mostly talking about pain right now, but when the nerve is impacted, as you mentioned, that could have sensory disturbances. You can have motor disturbances and reflex disturbances as well, right? So there's the difference between that would be like a radicular pain versus a radiculopathy, and that would be when you're having these actual disturbances in motor sensory function or reflex function. Um, so I think those would be really unlikely to see in the case of the somatic referred pain, right?
Yeah, absolutely. Yeah. You wouldn't be seeing sort of like those objective loss of functions. Definitely not.
Right.
The
So
um
then,
the the painful the radiculopathies as well. They again, it's quite rare for them to be painless. If there's no pain associated with them, then that's quite rare.
yeah.
And would be a bit weird and wonderful and would maybe sort of like, I guess, kind of like prick your ears up to try and distinguish what might be causing that. Usually
Hmm.
they're painful. They'll come with radicular leg pain as well.
Right. Yeah. When I had a cervical radiculopathy around this time last year, and when it started, I would say pain was the predominant feature of it. And I didn't really realize that I had any motor disturbances because I decided to just rest for a bit, right? I didn't want to go to the
Yeah.
gym or anything. But when I went back to the gym and I was on the bench press, I thought the bench was like on an angle or something. When I started pressing, I was looking around. I'm like, okay, I guess it's fine. I started to bench the weight again, and I'm looking at the weights to see if they're the same. And it turns out that I went to the shoulder press, and then at that point, that's when I figured it out that I had an issue with the nerve that innervates like my tricep.
Yeah,
I
C7. Yeah,
Yes,
yeah.
yeah. So I had quite a bit of weakness. I had about a 50% strength reduction in that side.
Really?
Yeah. And then that was lingering for a while without any pain. So that was the last
Okay.
thing to sort of get cleared up. So I think that was an interesting instance for me where I was like, I guess you can have these sort of motor disturbances without the pain. But it did not start off like that. It started off pretty painful. But it
The
leads me.
way
Sorry, go ahead.
Sorry, I was going to say the way I kind of explain that to patients sometimes, which is quite useful, like an analogy is with the radiculopathies, it's almost like an accident on the freeway or the motorway where you've blocked off a couple of lanes and the traffic slowed down. You've got a bit of a
Mm,
traffic jam where it's come to a complete standstill, perhaps it's slowed down to a fraction and the cars aren't going through quite so smoothly. Same with those signals that are being sent from the brain to the periphery, which can then cause, as you said, in your scenario, motor weakness, motor loss. Explaining that then to the patient is, over time, our immune system, our body tries to sort of attack that and improve it and help with recovery. The same as people would sort of, clear away the accident or clear away the roadworks, so the traffic goes through much more readily. It maybe doesn't work quite so well if someone's got a chronic like radicular pain or radiculopathy, but for those acute ones that you see, it kind of hits the nail on the head, I think, with people. They seem to quite like it.
yeah, I mean, it would have been perfect for me. If I didn't know what was going on and I saw you, that would have helped make it make a lot of sense. But it brings me to my next question. If you are working with someone and you test their reflexes and you see that they're impacted, or you test their myotomes and you see that something is off with their motor function, at what point do you refer them on? Is it in all contexts? Like as soon as you see something like that, will you then send somebody for imaging? Or are there instances where you're a little bit more comfortable just keeping it within a physiotherapy context?
Yeah, reflexes in terms of like areflexia, so where you might see like an asymmetry one side versus the other. I wouldn't say that influences my clinical decision making a huge amount for reflexes. Certainly, if you're seeing like very brisk reflexes, hyperreflexia, those types of things, again, we're going off on a bit of a tangent, but then I'm thinking, hang on a minute, is this perhaps something more, central? Is this an upper motor neuron lesion? Things
Hmm.
that I see in clinic quite a lot is like a degenerative cervical myelopathy. Those types of things might influence my decision making and threshold for referring on.
Mm.
The other thing as well is for people that aren't aware is you quite commonly see an absence of Achilles tendon reflexes bilaterally. I don't know if you've ever noticed that in clinic, especially with like older patients
Mm.
or patients that have like metabolic health conditions. The most notable is type 2 diabetes. Um, but it's quite common. So for diabetes and stuff, we know that influences like the muscle spindles and those nerve fibers, which can influence the reflex arc. But it also degenerates and doesn't function and fire quite effectively as we get older as well. So I think about a third of older adults, 60s onwards, give or take, can have absence Achilles tendon reflexes bilaterally. So
Wow, I
something
didn't know that.
worth considering. The muscle weakness, however, is quite different. So probably the key thing, and I'm a little bit cruel and a little bit nasty to people. I had someone today actually with sciatica. Um, is you've got to be quite firm when you're assessing them for muscle strength for the lower limb. Obviously, they're in a lot of pain and you've got to take that with a pinch of salt, but it's really important that you get an accurate test and an accurate measure for these types of things because a lot of the time it's just pain inhibition. They're in a lot of discomfort, so therefore they're not going to be putting their all into some of those tests that we do. So I sort of sit them down and I say, look, this is not going to be very pleasant for a minute or two, but it's really, really important that we do this to the best of our ability because it's going to influence with what we do next in terms of, decision making, treatment options, referring you on. So I guess that's a key thing just to mention. Um, it it depends. Again, coming back to Tom Jesson and Adam Dobson, I quite like their little mnemonic that they've come up with. So the three P's for myotones, which would influence your decision making and lower it for referring on to a specialist or referring on for imaging. So in this scenario, an MRI scan. So the first P would be polyroot, which is where you're looking at basically multi-level weakness. So, they've not just got a foot drop, but they've also got a really weak hip flexor strength, really weak knee extension. That's a bit weird. That needs to be investigated. That needs to be looked into pretty urgently. The other one is profound. So again, if we use foot drop as an example, unable to actively dorsiflex against gravity. So, a 2 out of 5, less than 3, that needs to be acted on really, really quickly. Because if it is something like, if it is a disc herniation and it's compressing L4, the sooner you can alleviate that, the better the recovery, the better the chances are for them to regain dorsiflexion of their foot. So
Hmm.
in Bristol in the UK where I work, they go to A&E with that. That's part of our local pathway. But that would depend in what setting you're working in. Some people it might be an urgent referral. If you're unsure, for someone like myself, I can contact and ring orthopedics or neurosurgery and chat to a specialist and get their advice, which is quite good.
Wow. Yeah, that's great.
And then the final one is progressive. So if you've got somebody and it's mild weakness and then it's gradually got worse, that's or it's very quickly got worse. Uh, Warning signs should be sort of flagging in your head, and you should have a low suspicion of referring them on. All of
Hmm.
those types of scenarios, I wouldn't hang around with that patient.
Right. Okay. So if you see maybe a little bit of a foot drop, and that's all, and their strength deficit isn't profound, it's maybe a 3 or a 3 plus, certainly weaker than the other side, but not to the point where they can't lift it against gravity, and that's the only sort of area that you find has a deficit. Maybe in that instance you would hold on to the patient. Am I understanding that correctly?
I think it would always depend on the scenario. I think if they've got just a subtle weakness in that foot, then it's a case of, giving it time. Safety netting is a key feature. So, discussing with them that if it was to get weaker, they need to come back to see you. If it significantly gets weaker, then they need to sort of act on that a bit more urgently and perhaps go to A&E or in Canada and the States, ER.
Mm-hmm.
Um, there is some evidence around, some subtle or some myotomal weakness being actually a positive prognostic factor. So again, coming back to those studies like the Atlas trial, so the one I mentioned at the start, um, the people that had a bit of weakness, they seem to recover quicker. I guess that the theory behind that is perhaps it's a bigger disc herniation, which might initiate a bigger healing response, immune reaction that then subsequently can settle and heal up a little bit quicker. Maybe, but that's just kind of the theory behind it.
Right.
But I
Yeah.
think if they're getting into sort of like the freeze, so there's not really a lot of active resistance against me, I would probably be wanting to scan that.
Mm-hmm. Got it. Okay. I think that makes a lot of sense. I think a lot of the time clinicians don't really know what to do in these scenarios because it's a little bit scary, right? When someone's nerve function is impacted. And I think it can be hard sometimes to differentiate, is this something where I need to refer them right now, or maybe will this get better on its own? And speaking of things getting better, let's talk about treatment now. As we discussed, if you go on Instagram or on YouTube and you type in, sciatica exercises or sciatica treatment, you're gonna get a lot of people doing just a million different things. all claiming that they have the best magic solution. You're gonna get people, as you said, like digging elbows into bums. You're gonna get people like stretching the nerve really hard. What like help us out, Charlie? What do we do when it comes to treating sciatica? Is there a best treatment? Is there something that you would completely avoid? Sort of help sort us out.
I don't want to be too pessimistic or too negative, but I guess at the moment we don't really have a gold standard. I wouldn't, and I guess that's kind of what I say to patients in clinic is there isn't something that can just completely help settle this. And a gold standard exercise, a gold standard treatment modality. Probably the biggest thing that we've got on our side is just time and natural history. Um, yeah, annoyingly, those people on TikTok and Instagram, they always seem to have so many followers as well, don't they? And it
Oh, of course.
generates so many views with the massage guns in the butts or these really aggressive stretches and things. For any sort of patients out there listening to this, watching this, I think if you've got people like that and they're offering that to you as a treatment, I would be a bit dubious. I'd be a bit skeptical if that's all they're offering. Um, I think for me, I guess because I don't work so much in a rehab role now, probably the biggest treatment tool is my voice, is my education, is my discussion around sort of, what the condition is, what the outlook looks like, that sort of thing. So giving them an understanding of what's going on, giving them, I guess, a natural history and a prognosis is really, really important, especially kind of what we discussed a minute ago for setting those expectations and understanding when it might be appropriate to refer to different pathways. So I will often say to people that this is something that absolutely is very, very debilitating and uncomfortable. So probably the first thing we need to do is get your pain under control. So that's having a conversation with somebody. In my scenario, it's the doctor, it's the general practitioner to look at some form of medication to help with them, and that should be in a stepped approach, I guess. You don't want somebody taking like fucking gabapentinoids and tramadol and like all of that sort of stuff straight away.
Hmm.
Ideally, not at all. So you start with over the counter. If that's not alleviating things, then you step it up and you look at some of the other things depending on their past medical history and the pros and cons of that. Um, Anecdotally, some people get quite good relief from some of like the tricyclic antidepressants, so things like amitriptyline, some of the serotonin uptake inhibitors as well, so stuff like duloxetine and those types of things can work quite well. But I guess the key thing is it needs to be prescribed by a medical practitioner, and that needs to be a conversation that looks into the pros and cons of that because there will be side effects with it. And we don't
Right.
really have any robust evidence. I don't know if you've looked on Twitter or now X, but some of the sports medical doctors they quite like the oral steroids like prednisolone and stuff short term.
Hmm.
Um, and I guess, the theory behind that seems pretty sound. Most of the time, it's an inflammatory reaction. So if you can control that inflammation, it might be helpful, but we don't really have any evidence around that. And again, there's quite a lot of side effects associated with it, really, at the minute. Um, when we look at like the natural history, then, so you've got the pain relief on board, and, perhaps we're sort of having a discussion about what sort of stuff they can do. Some of the literature that we've seen, it's probably looking at months rather than days or weeks
Hmm.
before we're seeing good, solid recovery. Um, Probably the biggest trial we've got at the moment is the Scopic trial, and that basically looked at people over a year. Um, and they looked at people that had just your generic usual care or people that had stratified care where they were sort of fast tracked into different types of treatment options depending on the severity and depending on the influence it had on them as a person. About 50% of them made a decentish recovery within sort of 3 months. And then roughly about three quarters in both groups at a year. If you I said I wasn't very good at looking at papers. Maybe I'm actually not too bad. If you look at the actual, if you get into the statistics around it, though, quite a small percentage fully recovered
Yeah.
at a year. Instead, it was 75% were either better, a good amount recovered or fully recovered. So I guess that's a key caveat when you're explaining things to people is you still could have some residual symptoms several months down the line. But what we should expect is that we're seeing a linear improvement over time. And if it's not improving over time, that's when we maybe need to come back to the drawing board and either reassess what's going on or maybe escalate things and look into that.
Hmm.
I'm
Yeah.
conscious I'm waffling. Do you want me to keep talking or?
No, no, no. I mean, that was great. I made like a very quick, like a 10-minute podcast last week on the Scopic trial. Um,
Okay.
and that was so if anyone's interested in what we're talking about, go check that out. But the thing about that is that we compared usual care to stratified care, right? We didn't
Hmm.
compare usual care to stratified care to no care.
Hmm.
So are you aware of research that looks at just sort of care for sciatica versus just sort of letting time do its thing? Like are we sure that treatment even helps?
So there is a couple of like literature reviews, meta-analyses, as far as I'm aware. So there was one in 2015 by Fernandez and colleagues, and that kind of looked at sort of advice and education, which is sort of creeping into a little bit of care. I guess you could argue that's going to have some form of contextual effects on their treatment outcome versus exercise, so like some form of exercise program. And the bottom line was, I think, sort of intermediate to longer term, there wasn't really any difference between the two,
Mm,
which I guess kind of supports that natural history. And then more recently, there was a big meta-analysis by Dove et al. In 2023, and they looked at again sort of exercise physiotherapy interventions versus just sort of like no care or sham, that type of stuff. Um, and there wasn't a difference really again longer
mm,
term in terms of how things sort of panned out and how what the outcomes were for leg pain and disability. There isn't there isn't really any good quality literature, I think, that looks at like good quality rehab,
mm,
like sound physiotherapy. It's all of the studies that they sort of piled into these reviews are really mixed. They're really heterogeneous. So some of them are like laser therapy or red light therapy, and then they're comparing that to sort of like core stability exercises, and then they're comparing that to neurodynamics. So you can't really sort of put your hat on what really works in these scenarios.
right. So what would you recommend to a clinician who is seeing someone with sciatica outside of nailing all of those important points that you mentioned for education? It's, I think, very important for the person to understand the natural course of the condition. Because if they
Mm,
don't, they're gonna again go to Instagram and they're gonna find that there's people out there that are offering a quick fix for their condition, and that then there'll be something very wrong with them when that fix isn't working for them. When in
mm,
reality, it probably never should have, right? They
yeah.
probably just need to heal. Um, but with that said, would you still, if you were in a role, let's say, where you were working with these patients a little bit more in their follow-ups, what sort of treatments would you offer them?
Yeah, I guess that would really depend in terms of what they're presenting with.
Yeah.
If possible, I would maybe keep it quite generic rather than specific. So some form of like whole body exercise could be quite a useful way of helping sort of treat them. A lot of the people, certainly in the NHS, I see as well, that they probably are a little bit overweight. They probably are a bit unhealthy. So if it can be sort of cardiovascular aerobic exercise, you're kind of getting sort of your bang for your buck and targeting two things at once. So some of that could just be like a graded walking program, something
Hmm.
along those lines, where you're getting somebody to exert and move their whole body. We know that sort of in animal studies and stuff, aerobic exercise might help with nerve healing, and we know that it can help with inflammation, which might then help with the recovery of this. But it's also going to have all of those other health benefits, some form of analgesic effect. It's going to help with our mood. It's going to help with our general health. But that could be any type of aerobic activity. If you've got access to the bike, as long as they're not really provocative with prolonged sitting, you could get them doing some form of bike program in the pool, hydrotherapy, swimming. There's lots of different options that you can explore with that.
Hmm.
Um, in terms of specific treatment, I guess you've got lots of different options that you could explore. Um, I quite like the sort of graded exposure to different sort of like movements, and certainly I guess targeting stuff that maybe isn't provocative to begin with, and then gradually building that up slowly. So usually it's like a flexed position, so bending of the spine that people don't enjoy. So perhaps getting them doing some stuff in prone, where they're extending the back, your cobras, that sort of stuff. I guess, that's kind of Mackenzie-esque, but I have no affiliation with them. Um, and then as that gets easier, you might get them supine, so sort of laying on their back on the bed, even doing just some deep breathing exercises, extending the back, trying to flatten it. You're going to get a little bit of flexion through there. You can then progress that to sort of heel slides, knee hugs, cat camels, child pose, seated flexion, and then perhaps some stuff over time where you're in standing and you're gradually getting somebody to flex their back.
Hmm.
All quite
Yeah.
useful things that you could explore, maybe.
I would say that's generally how I tend to approach it in the clinic as well. Like I make sure I
Mm,
hit home with the education bits. I could probably do a better job of referring people to get some analgesia prescribed to them. And then in terms of exercise, I usually take that graded exposure, graded activity sort of approach. One thing anecdotally that I've found when they're near ready to be in standing and bending over to sort of flex forward. I found that sort of like setting up a band so that
mm.
it unweights their flexion a little bit. I've found that sometimes that's a little bit more tolerable for people and they're able to bend over while they're standing comfortably, but then without it, they wouldn't be able to. And obviously that's at a very specific time point, right? And
Is that sort of around sort of the stomach or the chest or the hips? How do you normally set that up?
the way that I've done it is I had them in a squat rack and sort of
Yep.
strapped a band around the safety bars or sort of
Hmm.
where the notches are, where the barbell would typically go. And I
Mm.
have their hands sort of they're almost in this straight arm position and their hands are
Okay.
on the band. And then they're just sort of slowly bending over and then that band will sort of like help push them back up. So it just helps
Mm.
to sort of like unload it a little bit.
Nice. Yeah,
Yeah.
yeah, that's a good idea. I might
it's
steal that.
it's not like at a point where they're, like struggling to push the band down. I think that would probably irritate them a little bit. If they're, like having to brace really hard just to push the band down. I don't think that's the point of it. But yeah, I found
And
that to be helpful.
I guess the other disclaimer is you don't want the band to, you need a sturdy band. The last thing you want is for it to snap and for them
Oh
to face
yeah.
plant the floor.
Definitely. Yeah, you can typically do it with a thicker band, and that's the only way that I have done it with a pretty
Yeah,
thick
yeah.
one, but not so tightly wound where they have to, like if it was at neck height, they would probably have to like jump on it to get it down. So it's a little bit lower. Anyway, so I think that's useful for some people to sort of to try. And again, just because we have that research out there that shows that a lot of the time, like this sort of like advice and education in the long term tends to perform the same for these all the other treatments. As you mentioned, I think um, there's a lot of heterogeneity in that research, right? So for me,
Mm.
like I'm okay working with these people still and sort of seeing them, especially if they feel like they're getting benefit out of it. But I wouldn't do that at the expense of, like I think what tends to happen is people will not explain the natural history, and people will be there under the guise that they're seeing that physio in order to heal and to get better. And I don't think that's what we're really doing when we're working with people. Although that's not to say that what we're doing can't help, right?
Yeah, yeah, no, I completely agree. I think, I guess just being realistic and truthful with sort of the natural history, but then also, yeah, I think hopefully for people listening, it's considering that there are lots of contextual effects that we as physios can offer somebody. And
Mm-hmm.
I guess it's not completely throwing that out of the water just because we don't have any sort of piece of literature or evidence or research to say this is what you must do because this is going to get it better. So yeah, I completely agree.
Mm-hmm. Any place for manual therapy, do you think?
So, I mean, yeah, I guess so, definitely. Um, I'm, I guess my bias has always been a little bit against manual therapy, even though that I've like trained up in massage and bits and bobs, and then since I've worked in this role, I'm pretty much hands off. But I think, if you're good with your hands and you are honest as well with sort of the treatment that you're offering, and it's maybe with good, robust education in addition to some form of like lifestyle advice or exercise options, crack on and go for it if the patient's happy with it.
Mm-hmm.
Certainly for like, again, going off piste, but I find with a lot of like chronic sort of irritable neck pain, a good sort of masseuse, a good sort of soft tissue work and manual therapy in that region can be really nice and therapeutic. And I recommend that to people quite a lot. So
Mm-hmm.
again, people listening, if they're wanting to explore some of those options and they get some relief from it, fantastic.
Yeah, I'm on board with that too. I don't offer it to everybody, but some people, they ask for it sometimes, and if there's a big perceived benefit, again, as long as the explanations are there,
Mm.
I'm not they don't think that I'm healing them with my hands. I'm okay doing it as well. One last
And
question for you, Charlie. Um,
yeah,
sorry, did you want to say something there?
no, I was going to say, as long as I don't see you putting it all over TikTok or Instagram as well.
Yeah, I probably won't do that. Um, if we have someone, you mentioned the importance of or the potential importance of general health, right? Like with these walking programs, potentially cardiovascular exercise can help reduce inflammation and maybe that
Mm,
could help people heal a little bit better. Are you what's your confidence level when we're dealing with two people in a hypothetical scenario? They both have sciatica, maybe coming from a disc herniation, and one of them sleeps 2 hours a night and they smoke a pack a day and they drink in excess and they're very stressed out and they don't exercise versus someone who really tries to take care of their health because they have sciatica. Maybe their sleep is a little bit disturbed, but they're still trying
mm.
to sleep more than 2 hours a night. They don't smoke. They have good stress management. How confident are you in saying that that first person won't heal as well?
I guess we couldn't say with confidence that their recovery is any less than the sort of, healthier option.
Mm-hmm.
It- but I guess we just need to consider that they are some of the risk factors for sciatica, but also just any type of like musculoskeletal injury or pathology, which can make it become more persistent, more chronic. Um, so I guess they're kind of things that you may want to address in your
Mm-hmm.
session if you've built up that rapport and you feel confident enough to discuss that in a little bit of detail because yeah, there is literature around, metabolic health, so obesity, all of those types of conditions, smoking as well, and some of the literature is a big risk factor for the intensity or perhaps duration of sciatica. If you can get on board and sort of like signpost people to some options and sort of discuss those wider determinants of health and how that can influence people's recovery, even again, using an analogy, I guess it's kind of like there's lots of pieces to a jigsaw that can contribute to somebody's pain. And, maybe not the best analogy, but you don't have to fill in all of the pieces straight away. You can maybe sort of target one or two of those initially and say to
Mm,
people, out of what we've discussed today or out of some of those options, is there any of those things that perhaps appeal to you a little bit more? And then gauge what they think and sort of what they want to do. If they don't want to touch upon any of that, because smoking 20 cigarettes a day is what's getting them through their sciatica, then
yeah.
that's not the time or the place to sort of address that lifestyle factor. But if they're open to some of those things, then certainly in the UK and in the role I work in, there's lots of social prescribing services and sort of, clinicians or resources that they can access to help with it.
Hmm. Okay. So it's not to say that if they're smoking, there's no chance that they will get better. It's still possible that they can, and it's possible that, they're just they heal well, maybe genetically. And even though they have these things that we may think may affect their prognosis, maybe they're an individual who could carry on pretty well and heal well. But it can't
Yeah.
hurt to address those. And maybe it has a beneficial effect.
Yeah, maybe
I don't
some
know.
graded exposure to some systemic inflammation with the cigarettes, it might help them.
Yeah, I
But I'm
guess we
not
could
I'm
argue
not
that.
condoning that.
Of course, of course. Yeah. So I think it's tough to say, but yeah, I mean, can't hurt to try, I guess, right?
Yeah, absolutely. Yeah, 100%. I think that's that ultimately is what makes a good clinician. I think at the end of the day, to an extent, is considering some of those more wider determinants of health. And I know you're obviously really well read on it and aware of like the epidemic that is persistent chronic pain. And if we just solely focus on that spinal nerve root and not the person or not some of those other factors that can be contributing to it, we probably are going to get into a predicament at some stage where we're seeing a lot of people with a lot of chronic conditions and potentially a lot of chronic sciaticas that haven't been addressed at an earlier stage when they maybe could have.
Hmm. Yeah, yeah. I think that note about just treating the whole person and not the nerve root is a really good place to wrap everything up. Is there anything else that you want to comment on, Charlie, before we wrap up here?
Um, no, I don't think so. I guess the only thing I would say, and we don't need to go into a lot of detail around that today because that's almost a completely different topic. But if conservative efforts aren't helping, or perhaps we as we've discussed some of those risk factors or some of those prognostic factors, you can escalate their care. So if it's a raging, ridiculous leg pain, injection therapy might be an option for them.
Mm,
Um, Equally, if that's not worked or they've got a bit of weakness or they're not keen on injection therapy, sitting them down with a consultant to consider something like surgery. So, usually a microdiscectomy where they remove a bit of that disc to try and sort of free up and alleviate that nerve root, all can be and have been shown to be quite effective treatment options. So I guess it's just trying your best and that stepped approach to conservatively manage it as best as you can. But if we're maybe creeping into the several month mark and things aren't getting better, or certainly if things are getting a lot worse, there's no harm in escalating their care and getting a bit more of a specialist opinion.
good. Yeah, I think that's great to throw that in there. It's not like these surgeries and injections for sciatica are terrible ones, and
Mm,
so I think it's good to know that referral process there. It's useful and sometimes essential for people.
absolutely.
All right. Charlie, I think that was really, really informative. So thank you for joining me and chatting about this. I think it's going to help a lot of clinicians out. So really, really appreciate it. Where can people find you?
So I'm mainly on Instagram these days. My tag is actually the Fred Physio. That used to be because I used to write a lot of threads on Twitter, now known as X. But
Hmm.
if you just type in my name, then you should be able to find me. But if not, yeah, X, LinkedIn, but they're kind of the main ones really.
Okay. And your course as well. I'll link to that in the show notes if people are interested in learning a little bit more about being able to identify and rule out red flags.
Yeah, that would be amazing. Yeah,
Yeah.
yeah, yeah. And as I said, there's online options and sort of playback options and stuff. So even if you are sort of overseas, you can access it at any time or sort of within a certain limit. So yeah, absolutely, that'd be great.
Perfect. And just for the show notes as well, we mentioned lots and lots of papers today.
Mm.
I think you are pretty good at recalling all of them. We have the Steins paper in 2018. We spoke about the Scopic trial and the Atlas trial. A Nina Schmid's paper in 2023. So I'll link all of those in the show notes as well. Are there any others that I should include there?
Maybe the Dove et al. 2023 one that we
Okay.
discussed about sort of like the exercise treatment options versus perhaps like just standard care.
Got it. Okay. Perfect. Charlie, thanks again. I
Nice.
really appreciate it.
No worries. Thanks for having me on, mate. It was a pleasure.
My pleasure. Thank you once again for listening to the podcast. If you enjoyed it, please consider leaving a review. If you would like to follow me on social media, you can follow me at noahmandel.physio on Instagram and TikTok. Have a wonderful day, and remember to keep moving forward.